Okay, going on with dental implants. So restorations and prosthesis. This varies dramatically by the dentist. There's oftentimes a collaboration between the specialist. If the general dentist referred the patient to a periodontist or an oral surgeon, very oftentimes there is a collaboration on the restoration or prosthesis because it's important to the periodontist. That's kind of my perspective because that's where I worked. So, but I'm sure for an oral surgeon it's the same. It's very important, or they might also refer to a prosthodontist. Sometimes a prosthodontist places the implants and then restores it. So there's so many people that could be involved, but it's very important that that restoration gets special consideration so that it's cleansable, so that the patient can access it. So all these things. So the shade and the contour is very important consideration. The texture too. You don't want it to be gritty or something. And some restorations are better than others. The material that it's made out of, its profile, its emergence profile, interproximal space. Sometimes they have to shape things really weird, that's not like a natural tooth, but to make it fit the space, look natural, work, be cleansable, all these things. And then the way it contacts the tissue. It can't sit so close on the tissue that the patient can't get under it and around it to clean. So, sometimes you have to leave this open embrasure-like space so that you can get proxy brushes in there and clean around it and underneath it. Because if you can't clean it, that's, the patient's not going to have success long term. So their expectations and understanding of what it looks like, usually patients just care that if they smile, you don't see like a big hole. And so as long as it's hidden above their or below their smile line, patients are usually okay with however the restoration has to look. Material and design, it's an ever-changing industry in dentistry. Typically, the titanium is made out of, or the implant is made out of titanium, or a titanium alloy, but there are some ceramic, carbon, or other alloys. And then the material and design of the restoration, like the crown and the overdenture, is different too. It could be, any number of things. Usually ceramic is very common for like a crown. So it's usually the typical things that you would see. Zirconium, there's all these materials that are pretty often used in restorations of just regular natural tooth crowns, and you see those for implants as well. So there's something called there's certain things that as hygienists we need to be keenly aware of, so that when we're looking at x-rays, we understand what we're looking at, and then when we're doing maintenance and helping patients with education about their implant, that we are aware of these different parts. So there's something called a platform switch, and it used to be, and this is pretty common now, so I think most dentists and specialists understand this, and this is what you'll see most often. But there's something, if you look at this first x-ray, and you can see how the line from the abutment down to the implant is pretty smooth. This is how they used to do it, but in between the closure of the abutment and the implant, no matter how tight they torque that, there is still a space, and they call it a micro gap. And that micro gap is a perfect place for breeding bacteria, and there's no way to clean it. You can't get floss in there because it's a micro gap. And so what they found is that there was always bone loss down several threads, and they almost started thinking, oh, that might be normal. But then they realized that no, that's really doesn't have to be that way. And so now what they do is they call it a platform switch. So instead of the platform starting at the level of the implant, they have the platform tapered in slightly. They've moved it to the center, and now you can see it goes in at a tapered line, and it attaches to the implant in, sort of, not on the edges of the implant, but in. And that microgap is now closer into the center of the implant. It's not out by where the bone is. And so just moving that microgap, that bacteria can't bother the bone, and it can't cause the bone to recede. And so you can see here that the implant and the bone level are staying right at the top of the threads or above the top of the threads, whereas this, well, this doesn't really show the bone loss very good, but you would see in other images how after, you know, a year or whatever, usually you've got about 2 millimeters or so into the threads of the implant if you don't do this platform switch. So a lot of the time, this is what you'll see, and you might think, oh, something's wrong. If you saw it on an implant, why does it look like it's so skinny? But that's done on purpose. Okay, different types of attachments of the prosthesis to the implant. Basically, screw retained or cement retained. And cement is worth discussing at this point, as it has a fairly significant role in peri-implant disease. It can be a challenge to distinguish clinically and in radiographs depending on the type of cement used. So if they use a cement that is doesn't show up in a radiograph, it's translucent, then there might be all these issues around the implant, but you can't really tell what's going on because you can't see it until the dentist or the surgeon flaps back the tissue and reveals this big old chunk of cement, which is acting like a big old chunk of calculus. You wouldn't really necessarily know what's going on. You know, there's inflammation, there might be bone loss, suppuration, but you can't see the cement. So a lot of times the goal is to actually use a cement that is radiopaque so that it shows up in the x-rays. And but then the next challenge is removing the cement. You know, sometimes you can't remove it, so it still needs to be flapped back, remove the cement, tissue replaced and healed. Many studies have been published reviewing cement and its use in implant dentistry. Recommendations are often made for zinc-containing cement because of its radiopacity, its improved visibility on radiographs. It dissolves over time, so it might be there in the beginning, but maybe it'll go away. And its ease of removal, so you don't have to you might be able to slide your curette through there and pop it off. Many resin cements are in use, and some are not visible on radiographs, leading to the need for meticulous attention during cementation and during maintenance visits by the hygienist. This can be a nemesis. Trust me, it is very challenging to actually try to clean, like debride around an implant, and it can be a little nerving too. You'd be worried that, oh, am I scratching something? Am I even getting to where I need to be? It can be a challenge. So when something is screw retained, you can see that there's these little holes in the center of the crown, and the screw will set down in that. They'll torque it down, and it'll leave kind of a little gap at the very top of the crown, and then the dentist goes in and puts like a composite filling. So over here in this picture you can see these are the access holes. That it's just basically like composite filling on the top of the crown, and then these would be cemented in. There's the top is perfect looking. Sometimes people aesthetically like this better, but really in all reality, the screw retained is probably a better option, because you can remove that crown very easily. If something's going on, you can access the implant and see, and then you don't have the risk of the cement. So pros and cons, I suppose, to both, but sometimes they have to be cemented and they don't have an option to do a screw retained, but a lot of companies are actually really addressing that and making sure that all their implants, no matter what tooth in the mouth is being replaced, they can do it screw retained. Biology of teeth and implants. So natural teeth have a biologic width, a physical attachment that includes the epithelial and connective tissue attachment directly to the tooth surface via the Sharpie fibers. So that all those little fibers going right into the tooth. And then there's that space before where the bone starts, that little biologic width that sometimes the crown gets too close to the bone and it doesn't like that, and so there's always this inflammation in natural teeth because there's not enough biologic width there. The supracrustal and periodontal ligament fibers help to create a barrier to resistant periodontal breakdown. Implants, however, lack this same attachment and resistance to the breakdown, having only circular fibers going around the kind of, we call it like the collar, creating a tissue collar. So you can see there's fibers that go into the tissue, into the bone, and then there's fibers that encircle the top of the crown. And you want a nice tight collar around the top of the implant and at the base of the restoration. Another significant variation is the decreased blood supply around the implant, as there's obviously no periodontal ligaments or blood supply coming from the periodontal space. So those all really contribute to an implant susceptibility to breakdown and bacteria. So it's important that that we monitor that tissue. We see if it's bright red, is it light pink and firm, is it bright red and spongy. You want to monitor and assess that tissue at every single visit. Keratinized versus non-keratinized mucosa. So you can see here, just like in the mouth, when we have that bound down, tough keratinized tissue and we have a width of it, we want a bigger width of it on our natural teeth and around our implants. Now, sometimes it's just not really possible. Sometimes people have a very limited amount of keratinized tissue around an implant and there's really nothing that can be done about it. So then they just need to be educated that this is your situation. You want to take extra care, lots of good oral hygiene, and then we'll pay attention to this area. I've seen lots of patients who have no keratinized tissue. It is all non-keratinized, super soft and movable, and that is just what they have, and they have no choice but to have it. And I've seen some that have no inflammation, mild inflammation, or severe inflammation, and you just have to do what you can, let the patient know what is happening in their mouth, talking with the surgeon or the specialist about if there's better options or if surgery to try and graft in tissue is even possible, may or may not be. But it's our job to know what we're looking at and help the patient understand their particular situation. And of course, think to yourself, why is it important? Why does it matter if it's keratinized or non-keratinized? We know from just with natural teeth that keratinized tissue is tougher and it's like a barrier. So the softer tissue is more prone to break down easier. Okay. Maintenance and the role of the dental hygienist. So our role is basically identifying, evaluating, documenting, educating, just with everything else. It's the same thing. We are the ones that know and can look and see. We alert the dentist, we alert the patient, we alert specialists. So it's our job to keep tabs on all of this for patients and then educate them and let them know what's going on, their risk factors, all of that. Asking them questions, finding out, what's going on, if they've been having pain, if they've noticed changes, all of that is our job. So continuing maintenance. So assessment is really important, to take a thorough assessment. And what is that going to consist of? Every appointment. This is every appointment. So if your patient comes in every 3 months, then this happens every 3 months. Sometimes images are only done once a year, once they're kind of stabilized. But if something changes, if something is looking funny, then you need new documentation. So you're going to always do your health history. You're going to always take note of the oral mucosa condition and what it looks like. You're going to always ask them about discomfort, pain, complaints that they may have around the implant. You're always going to look at the tissue for the color, the texture, the overall condition of the mucosal peri-implant tissue. And then you're going to measure the following. You're going to measure the amount of attached tissue. You're going to take a periodontal probe reading. You're going to record whether or not there's bleeding or not. You're going to record whether or not there's exudate or suppuration, pus coming out of the sulcus. You're going to record the amount of biofilm. Are they doing a good job cleaning out that biofilm, or is it, or not so good? Oral hygiene knowledge and behavior. What are they doing and how often? And do they realize the importance of what they're doing? Mobility. You're going to take the blunt ends of two instruments and check for mobility. It could be if you get movement, it could just be the restoration, but it could also be the implant, and that would be a big deal. So you're going to check for mobility, but you're also going to check for interference. If there's heavy occlusion on something, on an implant, that's not a good thing. The forces should not be heavy on it because there's no shock absorbers, there's no periodontal ligaments. So they shouldn't have heavy occlusal forces. You're going to check for change in radiographic marginal height. And with this, well, we'll talk about this. I'm getting ahead of myself. Presence of mechanical problems with the prosthesis. You're going to evaluate all of that at every appointment. That's your checklist. Boom, 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 boom. Signs of disease. So the things that you're going to see, this is just kind of reiteration, but obviously increased probing depth, suppuration, bleeding, signs of inflammation, swelling, color changes, and then that radiographic loss of bone. All right, so probing, the American Academy of Periodontology recommends both probing and radiographic assessment in order to diagnose peri-implant disease, and states that the initial probing should be done once the final restoration has been placed using a traditional probe with light pressure. Plastic probe, metal probe, which one? Traditional is fine. There are some pros and cons to either, or you think about the odd bulbous shape of an implant and the rigidity of a metal probe. Sometimes the plastic probe might bend a little bit better, but it's fine to get into the area with a traditional probe, and it might be preferable. Light pressure is the key. Angling it well and light pressure. The implant probing depth may be greater than 3 millimeters initially due to the depth of implant placement or prosthesis design. Very common to get more than 3 millimeters. 4 millimeters, even 5 is not uncommon. Bleeding and tissue appearance is what you really want to know. Historically, there has been some controversy regarding the use of a probe on implant. This stems from the concern that periodontal probing can break down the fragile epithelial attachment around the dental implants or scratch the titanium surface. The available research does not suggest any harm to the implant surfaces or to the prognosis of an implant with careful and proper periodontal probing. While the use of plastic probe has been suggested, there is no evidence that it's necessary, and it's imperative, however, that there be consistency. This is kind of the key, that there's consistency in the type of probe, the angulation used throughout the dental office in order for the validity in the interpretation of the changes in the recorded probing depth. So as long as there's consistency of the person who's probing, the angles, the type of probe used, so that one person's 3 isn't another person's 5, you know what I mean? That's the part that really matters. It is also important to have the radiographs available when probing, as implant diameter is variable and the size of the prosthesis does not indicate the width of the implant. So you want to be able to see visually your implant on the radiograph to help you kind of guide you subjectively what other areas you can't see. So radiographs. So here are images of what you may see in practice. You may see the initial placement. This is a 2-year follow-up. Clearly there's been a fair amount of bone loss around the implant. And if you take a radiograph, you want to make sure that you're taking it in a very similar angle so that you are seeing the same view as much as possible every time you take a new radiograph, so that you can compare the bone level accurately. It's important to note that some initial bone remodeling will occur in the first year, and it is considered within normal limits to see remodeling of up to 1 millimeter. So some loss of bone up to 1 millimeter is normal. It's also important to remember that the angle you expose the film will affect the way the bone level looks on the radiograph, and also you cannot evaluate the buccal or lingual bone. So you have to remember that radiographs don't show you buccal lingual bone. Maintenance, PeriImplantitis, loss of crestal periimplant bone in conjunction with bleeding upon probing, mobility of implant structures indicates complete loss of osteointegration. If that implant is moving and it's not just the prosthesis, then you have lost osteointegration, and that's a total implant failure. There's no recovering from that. They need to start over if that's possible. The first step in management of PeriImplantitis is to identify and remedy the local factors in the etiology. It could be retained cement, it could be poor contouring, it could be just the patient's not caring for it, but you got to figure out what's going on. Non-surgical debridement in conjunction with medical management of the inflammation. Surgical therapy includes granulation tissue removal, some kind of a periosurgery or oral surgery around the space. Oftentimes the hygienist will look at it in the beginning, say, can I manage this? Maybe they'll give it one recall appointment. If they come back, nothing's better, they're going to say, you need to go back. This is something I can't manage. Something else is going on here. You need to see the specialist and get this under control, or else you could lose the implant. So that's our role again. We do what we can, but we know when to say when. And we know when to say this needs to be referred out because I don't want you to lose your implant. Peri-implant disease. So it's important for you to know the difference between peri-implant mucositis and peri-implantitis. These are two different things. Think gingivitis and periodontal disease. So mucositis, gingivitis, implantitis, periodontitis. It's kind of similar, so you can read through those definitions. Risk factors for peri-implant disease. So people who have struggled with previous periodontal disease, if they smoke, poor plaque control, poor prosthetics of design of the restoration, uncontrolled systemic diseases, or diabetes. So let's talk about the Armamentarium a little bit. There's a lot of research on this. What do we have in our clinic? So actually, when you have a little bit of time in clinic, find out from whoever's in there where the implant instruments are and what we have available. What type of implant instruments do we have? I know we have plastic, and I think we have some titanium, and we may have a different, we do not have the glycine air polishers. I would love it if we did, maybe one day, but we don't have that. And then we want to think about polishing and what we use around the implant for polisher. Gel, dentifrice, tin oxide, or non-abrasive prophylaxis paste. Rubber cup and pointed polishers are actually not really recommended because there are there's evidence that it can leave a debris around the implant or down at the base there. So I think I'm gonna have to consult with Holly and Monica, but I almost want to say that we are recommending just toothbrushing around it. Now I'm thinking we'll have to get back on that, or talk to the faculty, clinic faculty, about it too. If you have a patient in your chair, then find out what they recommend. I know people do use rubber cups and pointed polishers. I think if you use a very light pressure and you aren't, usually there's not a lot of stain. Very, very rare for stain to build up around an implant. So usually you can do most of your deplaquing with flossing, brushing, proxy brushes. So thankfully you can do most of that way, and you don't have to polish the heck out of it. I would recommend not doing that. Okay, Different types of scalars. There are Teflon coated, there's gold, there's titanium. Ultrasonic scalars, they have the little plastic tip. There are studies that show that that little plastic tip that goes over a scalar or a plastic ultrasonic scalar can leave, again, embed plastic into the implant. When I was at the periodontist I worked for wanted me to just use a regular ultrasonic tip. Here's the caveat though. I did not take my ultrasonic tip and like hold it into the implant and like, I took the tip and I lavaged around gently to lavage out biofilm around the collar of the implant. And so I was not really touching the implant with the ultrasonic. So it's technique sensitive. He felt that it was better that I do that and lavage and de-biofilm down in that area than not. So it really kind of depends on the philosophy of the dentist you work for, your comfort level, research, do your own reading, see what you feel comfortable. But that is what I did when I was in private practice. Here's a little study results about titanium implant scalars. You can read that. And then oral hygiene. So oral hygiene, it's very important that patients have access and that they have a good routine. They can use their toothbrushes at that 45-degree angle, our basilocular method. Power toothbrushes are wonderful. 2 rows of bristles. The Intuff and interdental brushes are wonderful, and the nylon coating over the metal is very important, and a lot of the good brands have that. Rubber tipped stimulators to stimulate the tissue, keep it healthy, keep the blood flow going, but also to remove biofilm. Low abrasive dentifrice or toothpaste, and then dental flossing. Usually it's nice to have one that does not shred easily and a little bit thicker. And then oral irrigation also is wonderful, and they can add a little bit of something. If they struggle with keeping areas clean, they can use a very diluted bleach solution in their water irrigator, or they can use like mouthwash also. And then low force, generally speaking, is important, but they also want to use the water flow long enough that they disrupt the biofilm. Flossing around an implant, we talk about the shoe shine method, and this is very good because that method will clean around the whole circumference of the implant. And so what they do is they will floss it. If they have their implant here, they want to encircle. I can't get my, oh my word. Oh, look, there we go. So if this is the tooth here, they want to encircle the floss over the coming out the buccal, the mesial and the distal, and then they want to cross the floss. So you'll cross it and then you'll shoe shine it. And in that way you get the circumference of the whole implant. However, it's important that the patient is aware of the type of floss, and if they can tell that something is shredding, you know, there's that micro gap, or maybe not so much the micro gap, but if the dentist didn't seat the prosthetic well enough, there could be some kind of something that could catch the floss, and then they could have shards of floss below the gum. And that's, of course, just going to be something that could get more bacteria. So it's important that they're aware of that. And you can test it out in your office while you're showing your patient. See how smoothly it runs, and then take it out and see if anything's shredded. Let's see. And it could be catching also on cement too. That's another good way to see if it's if it's catching on anything. And I just wanted to go back here to show you, like, this is a full denture on implants, and patients need to be able to access underneath it and run that floss through. So if it's too tight or up too high in the vestibule, it can be difficult for patients to access. So part of what we do is we're assessing and seeing how well the patients can clean around these areas. And then last slide here, implant failure. Implants ultimately fail due to loss of osteointegration. Removal of an implant is the only option possible to have implant replaced, but oftentimes they need to have bone grafting and a healing, and it's the whole process from step one and it's not always an option. Important to understand why the implant failed in the first place. Surgical therapy is really superior. This is kind of a star, because oftentimes we think of ourselves as the maintenance for perio maintenance for perio disease, but with patients with implants, we can only do so much, really, and we need to know when to say when. And a lot of times, surgical therapy is superior to our maintenance therapy in resolving PeriImplantitis. If it's just mucositis, that's different. But if it's PeriImplantitis, it oftentimes needs some kind of surgical attention to find out what's happening. And so ultimately, a referral back to the specialist is oftentimes needed. Sorry, you guys, 30 minutes. That's a long one. I should have ended sooner, but I didn't. Okay, make sure you put your questions in if you have any. See you next time.